Welcome everyone to the April KPQC Learning Forum. Excited to have you today. I'm going to work on admitting people into the waiting room. And okay, Terry, do you want to get us started?
You bet. Hi, everybody. Happy April. Glad that you're here. We have just a few announcements, our typical stuff before we turn it over to a phenomenal guest speaker that you all will recognize today. But first, if you'd put your name and your agency/hospital in the chat, that helps us give you credit for being here. And also we watch our numbers and make sure that we've got the engagement that we want across the state. Next slide. So the big topic in our world right now is the conference that's coming up next month, May 23rd. We will be hybrid again. And so in front of you, just to make sure it's super clear for everybody, the virtual option, the virtual portion of our spring conference for the KPQC membership. So everybody that's not a champion or executive committee or leadership, but everybody that's on the KPQC membership is invited and encouraged to attend virtually the conference on the 23rd from 9 to essentially 11:45 noon. Registration is there. Tiffany, if you'll do me a favor and copy and paste that in the chat, that might be helpful for folks to just link in directly. Immediately you will get a verification that'll tell you about how to log in that day, send a reminder in your calendar, all the important 2023 Zoom things. And we look forward to you joining us virtually for those really great topics for our keynote speakers, but also we're going to be giving lots of updates across the state in terms of what's going on with the 4th trimester initiative. So we're excited for that spring conference. Next slide. The other portion of that, the same day, same experience, is that the 4th trimester champions and those of you that we've reached out to individually are going to join us in person. So in person, getting the same conference materials that everybody's getting in the morning. And then we're going to let everybody go that's virtual and stay in-house in Topeka and do some deep dive work that we're really excited about. On the right-hand side at the very top is the champion registration link. And so again, not to be confusing, but that's only for champions. They're going to be attending in person. If you have questions about that or aren't sure where you're supposed to register, please reach out to us right away. Tiffany, Jill, Carrie, or I, and we will get you set up right away. But again, we really, really, really want and expect for every champion to be there. If champions you cannot attend on the 23rd, reach out to the person who you work with the closest that is able to attend for you. That is absolutely okay as long as they're prepared for that meeting and kind of know how that will go. Certainly they're good representatives of your hospital or birth center, but we certainly want to make sure that they're set up for success that day. What to bring. So I've included this in an email, but I wanted to make sure it was clear. What we're going to go through and the next piece or a couple pieces of our 4th trimester initiative, specifically these two pieces that are mentioned in the bullet point to the right, the postpartum discharge summary and your social determinants of health screener. Now, if the answer is we don't have either of those at our hospital, I'll be shocked. I think the truth is you have some version of those things that you're doing. And we're going to work together with you to see what your baseline is. Does it meet the criteria of the AIM bundle that we're all hoping to synchronize in Kansas? And if not, what can we do to help get that in the next year up to speed? Or for those of you that have all those things in place, you've got an awesome social determinants of health screener. You use it to refer a patient for X, Y, and Z. Boom, outpatient discharge is set up. We may use you as an example that day of the good work that you're doing. But those two pieces can either be brought on your laptop. We'd prefer them in paper. Bring copies of your hospital's postpartum discharge summary, I'll come back to that, and your social determinants of health screener. A lot of folks that have reached out to me about the social determinants of health screen are saying it's questions in your EHR that are kind of embedded through your admission assessment, or noted on the discharge for referral. I will tell you that if you think it's related to social determinants of health, it's part of that screen. So just bring with you whatever you've got. We are not expecting everybody has a screen and then everybody is prepared for this conversation. We're just going to get it started and help out. On the postpartum discharge summary, we're asking for the provider version, the part that again, if we were going to replicate or send that summary home with the patient, would have had everything that's necessary for the next person in line who wasn't at her birth or in her postpartum care to know exactly what happened at her birth and in her postpartum journey in the hospital setting, right? So sometimes there's an infant side or an infant maternal discharge summary that has just appointments on it, or, the post-birth stuff. That's education. I'm talking about the information like vaginal versus cesarean, twin versus singleton, IUFD, what were APGARs, and then certainly any postpartum complications or medical issues. Was she hypertensive? Did she have thyroid disease? That kind of stuff is what we're looking for. Okay. So again, I'll send out some more reminders. We'll be more clear about that as we get closer, so make sure you guys have questions answered, but that's what we want you to bring. And then please wear, if you have your 4th trimester t-shirt, we're asking you to wear them to the in-person conference that day. Okay. Next slide. And then exciting news for the 4th trimester group. We all want to welcome and celebrate that the University of Kansas Great Bend campus is our latest facility that's enrolled. We are now up to 31 total facilities that are enrolled in the 4th trimester initiative, with 2 to 3 waiting in the wings to complete documentation or to complete enrollment packet. So sometimes we go through kind of a lull where we don't have many that are enrolling, and all of a sudden we've got some great facilities that are coming on board, and we're thrilled to have Great Bend join us. Next slide. So just as a reminder, and there's my note to myself that says, I need updated demographics. We now represent over 83% of births. It's like 83.4 or something. So I want to put 84% of births really bad, but we're going to get there. Of course, our goal initially was 90% of births in Kansas. And I would tell you our internal goal is that we're going to hit 90% by the end of 2023. That would mean more hospitals across the state, not just the big guys, not just the big hospitals, but also the smaller rural sites. I also want to provide to you guys this next year, what is the makeup of our birthing persons? What's the makeup of our hospitals and birth centers? That'd be kind of fun, I think, for you guys to know, because Kansas is pretty dynamic. That's why that picture, I still use that. We've got birth centers, we've got big hospital systems, we've got rural centers that are absorbing a ton of the OB deserts happening in certain parts of our state. And I get to hear their stories. We get to hear their stories. We want to share them with you. But welcome to Great Bend. And to those of you that are thinking of enrolling, we want to hear from you. Please join. Next slide. And then this is an outdated picture. I think if you'll notice her live picture versus her current, this picture I pulled, this is a purposeful moment where I get to introduce one of my favorite people that I did not know before I got involved with this work, Dr. Courtney Bettinger. She serves as our newborn screening. What's the official term? Hold on. I'm going to pull it out, Dr. Bettinger. It is newborn screening medical director. Yes. So I'm not sure how many titles this woman has, but I met her as our pediatric champion. Of course, she was the chair of our KPQC just in the past recent few years. And in my mind as a midwife, she is a newborn think tank of what's going on in our state. Where do we need to be focused on? And her hand goes up to go, don't forget the babies. Like, I know you guys are focused on maternal health, but don't forget the babies. And so today we're not going to forget the babies. Dr. Bettinger, will you introduce yourself and jump in here?
I would love to. Thank you so much, Tara. That picture is, I was really pregnant. They cut out my belly, or maybe you cut out my belly, but I was very pregnant in that picture. It's like a flashback. Let me get my screen sharing going here. Let's see here. All right, let's get this up. Okay, so thank you so much for the introduction, Tara. I'm a general pediatrician at the University of Kansas in Kansas City, where I do clinical work in our pediatric primary care clinic, and I'm also serve some time every year, a few weeks, and then in our hospital's newborn nursery. And I love taking care of newborns, and I love everything really about newborns. My current research involves safe sleep practices with our clinic, nursery and NICU babies, and I'm also doing some work on improving newborn resuscitation outcomes in the Democratic Republic of the Congo. Like Tara said, I am on the executive committee of the KPQC. I was the chair in 2020 and currently the medical director for the newborn screening follow-up program. I'm so excited to be here. This was such a fun talk to put together and really excited to share. I will tell you, I don't know how well you can see my eyes, but I'm recovering from pink eye. So hopefully there's not too much distraction there. It looks a lot better than it did. All right, so here's an overview of the topics that I'm going to cover. I'll let you read through those. And the photo on the slide, that's my son, Peter. He's one of my 3 kids, not who I was pregnant with in that original picture. All my kiddos were born in Kansas hospitals. My husband's a lifelong Kansan, and he was adamant that they be born on this side of state line, which has worked out well because I have experienced newborn screening and newborn care quite a bit across the spectrum, which I'll touch on throughout the talk. Sweet little Peter here, we're going to talk about newborn screening, and he had an insufficient sample, which happens from time to time. So got to do that, like taking him back to the clinic to get an extra draw there. So let's start with the infant mortality rate. So the infant mortality rate tells us how many infants less than a year of age died during a certain amount of time. So this is over the course of the year of 2020, and that is per 1,000 live births. So the state of Kansas in 2020 had an infant mortality rate of 6.6, and this shows you how we compare to other states. This tool from the CDC goes through several different years, and if I had clipped the one from 2019, it looked a lot better. We were at 5.42, which was the lowest that it had been in several years. And most of the years we were around 6, or in 2020, 6.7. The nationwide infant mortality rate in 2020 was 5.4 deaths per 1,000 live births. So we are unfortunately behind. And the World Bank ranks the United States number 55 out of all the countries in the list for its infant mortality rate. The Healthy People 2030 goal is having an infant mortality rate of less than 5. So we are hoping to get there and working hard to try to get there. Okay, let's see. Sorry, I have my notes on one computer and the PowerPoint on the other, so I'm just getting myself comfortable here. All right, so the good news overall, though, is that the infant mortality rate in Kansas declined significantly from 2007 to 2019. So like I said, there's the infant mortality rate from 2019. The not good news is that much like in maternal mortality and morbidity, we are seeing significant race and ethnic disparities when we look at infant mortality rates in Kansas and we break it down. So you can see here that for non-Hispanic Black births in 2019, it was 10.7. The infant mortality rate among non-Hispanic Black births remained at least twice that of non-Hispanic white births for most years from 2000 to 2019. You can also see on here that the leading causes of infant mortality from 2015 to 2019, so congenital anomalies, sudden unexpected infant death is number 2, so that's where my research is, short gestation and low birth weight, and then maternal complications of pregnancy. And as I'll get back to at the very end of the presentation, you can see looking at that list how important what's going on with the 4th trimester initiative is, and how important it is that we have me and other pediatricians representing the pediatric side to have a voice and a reminder of the role that maternal health plays in how our babies are doing. And then I feel like it goes vice versa. It's also like, and when I'm with my colleagues, I'm trying to advocate for us to be keeping in mind maternal health as we are doing interventions and doing our social determinants of health screen, for example. All right. So a big thank you to Brenda Bandy. She's the co-executive director of the Kansas Breastfeeding Coalition, and she put together most of the next few slides so that I could optimize my depiction of breastfeeding in Kansas. And you'll note the KBC logo in the lower right-hand corner of all of her slides. So we're going to talk about breastfeeding in Kansas. And this slide shows us that Kansas is above the national average as far as breastfeeding rates at different points. So that's wonderful. We are not at the Healthy People 2030 goal, but I'm really excited that we are above the national average. So here we have a similar to the map I showed you earlier, in the sense of it's the same kind of map, but not the same data. We are number 14 in the nation in the percent of infants exclusively breastfed through 6 months. And then here we have a map that breaks it down by county. And Brenda informed me that we have a great sign of progress here, that the map is more pink than ever before. So pink represents counties that exceed the state average in breastfeeding initiation rates as measured by Kansas birth certificate data. Lane County leads the way with 97.6% of families starting breastfeeding at their child's birth. The counties in white have breastfeeding initiation rates lower than 80%, and this is often a sign that many families simply don't see breastfeeding as an option given their circumstances. And as I think all of you know, we all have a role to play in removing barriers and helping to encourage breastfeeding for families all over the state. And so here is another breakdown by race and ethnicity, and you can see that we have significant disparities in breastfeeding rates as well. So most Kansas families we can see on here choose to breastfeed, but unfortunately not all families, and I think a lot of families don't see it as an option for them. And so it is one of our jobs is to try to help counter the structural barriers and historical trauma that make it more difficult for Black, Indigenous, and Latina mothers to engage in this practice, which has such important positive health outcomes for babies and moms. This is a reminder of the Baby Friendly Hospital Initiative. I'm sure you've all heard of it. So the goals of Baby Friendly are to really to optimize breastfeeding. So number one, making sure everyone understands that direct breastfeeding is the optimal way for human infants to be nurtured and nourished. Number two, that the first days in the birth facility, should be protected as a time of bonding and support, not influenced by commercial interests. And number three, that every mother should be informed about the importance of breastfeeding and then respected to make her own decision. Kansas ranks 8th in the nation when it comes to the percent of babies that are born in baby-friendly hospitals. So we're at 56.8% compared to 29% nationally. So that is wonderful. Great work, everybody. And here we have a list of our baby-friendly hospitals in the state. Finally, last thing about baby friendly is that this slide nicely shows that as the number of baby friendly practices that are reported increases along the bottom there, let's see, I have to remind myself. Okay, so it's a little bit counterintuitive. So the percentage of mothers who stop breastfeeding before 6 weeks declines significantly. And so it's good that we're seeing that decline, which means, although it's declining, it means that there's more breastfeeding going on. So we like to see that. All right, now we are going to talk about newborn screening. I spend a lot of my time thinking about newborn screening, which is wonderful. So just a quick background, newborn screening started in the 1960s with dried blood spot screening for certain metabolic conditions. PKU was the first. The goal of newborn screening is to catch conditions that are not otherwise recognizable in the newborn period, but benefit from early detection. So if there's an early intervention, it improves the outcome. The federal government sets the RUSP, or the Recommended Uniform Screening Panel. It currently has 37 conditions, but each state determines which of those conditions and potentially more they screen for. Excuse me. So Kansas screens for 34 of the 37 conditions. We are working to add other conditions, which I will touch on a subsequent slide. And you can see here that the components of the newborn screening. So hearing screen, critical congenital heart disease screen, and the blood spot screen. I'm going to dive into those a little bit more as time goes on. And then a reminder that all babies should undergo newborn screening regardless of place of birth, health insurance, gestational age, etc. And I put an asterisk by all because unfortunately there are going to be babies who aren't going, maybe they pass away, or they're on palliative care, or they aren't projected, to make it more than a few hours. So not every single baby, but almost every baby. And as a clinician, I think of it as all babies because I wouldn't take care of babies who are who don't qualify. They would go to the NICU or stay with their mamas without us intervening typically. So newborn screening in Kansas, we are always working to do a better job. We want to decrease our processing time. We want to increase the percentage of babies who are screened. We want to increase the conditions that are covered and streamline the reporting of abnormal results. We are working hard to align with the recommended universal screening panel, like I talked about. We have an advisory council, which is appointed by the Secretary of Health. It has 17 council members that cover a wide range of those who are involved in newborn screening and or the conditions that are screened. We meet about 2 to 3 times per year. Our next meeting is on May 11th. It is open to the public if anyone wants to attend, and we are recruiting new members. So please let us know if you or anyone is interested in considering us. We are in particular need of another pediatric hematologist, a pediatric endocrinologist, family physicians, neonatologists, and pathologists. So if you are any of them or know any of them, we would love to have you in particular on our council. An important thing about Kansas, which is so wonderful, is that our blood spot screen is provided at no cost to babies and families. We are one of 2 or 3 states that is the case. And I think that really helps us get at least one of the barriers down to getting all the babies screened. And as you can see on here, you might recognize it. Here is a clip of what the blood spot, the card looks like or the blood part of the card looks like. All right, so I'm going to go through each of the sections of newborn screening, and there's not anything too detailed, so it won't take too long. So newborn hearing screen, which is called Sound Beginnings in Kansas, is essential. So as you can see in this red box, about 2 to 3 babies per 1,000 are born with hearing loss. And of those babies with hearing loss, about 90% are born to hearing parents. So yes, every baby needs to have a newborn hearing screen. The goal for hearing screening is that the hearing screening test should be done for all babies within the first month of life, that a diagnostic evaluation is done no later than 3 months of life if they fail the hearing screen, and that early intervention is started within 6 months of age if the baby is diagnosed with hearing loss. And that's because we know that the sooner we get, we intervene, the sooner or the better the outcomes are for the baby, and the more they're set up for success. So there are 2 ways to do the newborn hearing screen. One is called the Automated Auditory Brainstem Response, or AABR, and it measures the brain's response to sound using electrodes. The other, excuse me, the other option is otoacoustic emissions, OAE, which measures the ear's response to sound. If whichever one is done, if it's not passed bilaterally, then the baby needs to have a screening as an outpatient. And I consider that to be one of my most important jobs in the nursery, is to make sure that any baby who isn't screened, that I get a warm handoff with the PCP so that they know, particularly if they're following up outside of our facility, that the baby needs to be screened again. Here are the data for the last 2 years in Kansas for newborn hearing screen. As you can see, we have about 99% of babies born in Kansas in the last 2 years have been screened, which is great. We're trying to get to those last 1% to make sure everybody gets screened. In 2021, there were 100 true positives, and in 2022, not all the cases have been confirmed as true positives, but what we have right now are that there were 68 positives. So we are right at that where that red box said, so 2 to 3 cases per 1,000. All right, next we'll talk about the critical congenital heart defect screen. The goal of this screen is to catch babies with critical congenital heart defects who are asymptomatic. An estimated 875 babies are true positives in the USA each year. And in 2021, Kansas had 41 failed screens that resulted in 3 diagnoses of a critical congenital heart defect. Of those other babies, so the 38 other babies, 19 of them ended up having nothing wrong with them, and 19 ended up with other diagnoses that explained why they failed the screen. As you may know, the critical congenital heart defect screen is really a simple screen. You just take a pulse ox and you put it on the baby's right hand, and then you put then you also check the pulse ox on one of the feet. So you're checking to see how the oxygen level is. We call it preductal, which is before there's a spot for the blood to deviate, and then also postductal. And if the oxygen saturation is less than 90%, then we consider that screen a fail. If it is less than 95% in the right hand and the foot on 3 measures, each separated by an hour, we consider it a fail. And then if it's more than a 3% difference between the right hand and the foot, again, on 3 separate measures, then we consider that a fail, and they need to have more done. In our hospital, we send them to the NICU and have them get an echo typically. So I love the heart physiology that happens with the transition from fetal to neonatal life. I just think it is one of the most miraculous things there is in this world. I won't go through it too much. I know that everybody loves it like I do, but essentially, here in the neonate, or in the fetus, there is the ductus arteriosus that I was talking about, and it is open. And then while the baby is inside mama, most of the blood is diverted from the lungs because it's not getting oxygen through air, so it gets diverted and is getting oxygen from mom. And then when the baby comes out and starts breathing on his or her own, the pressure increases in the lungs, and that opens up the lungs, and blood is going. No, sorry, the pressure decreases in the lungs, blood goes to the lungs, and that ductus closes in the first 24 to 72 hours or so. And so one of the reasons that we recommend doing the CCHD screen after 24 hours is that we're more likely to catch things because of the changing in pathology, and let them get through at least starting that transition to extrauterine life. Here are the 7 target critical congenital heart defects. There are a handful of others that also may be caught on here. And then there are, like I said, so half of the babies that screened positive, almost half, ended up with a non-critical congenital heart defect as a cause for why they failed the screen. So some of those reasons might be hemoglobinopathy, hypothermia, infection, sepsis, lung disease, persistent pulmonary hypertension, a non-critical congenital heart defect, and other hypoxic conditions or conditions where babies have low oxygen levels. All right, next up, the blood spot screen. Oh, and I'm sorry, I should have said this at the beginning. If you have questions, feel free to put them in the chat. And I believe we got someone watching the chat to let me know if anything comes up. So I'm happy to answer as we go along. So the blood spot screen, this is a nice timeline that KDHE published to help people understand what our goals are with the blood spot screen. So the blood spot screen is what a lot of us think about as the newborn screen. Sometimes it's mislabeled the PKU test, at least where I work it is. And that's because, like I said earlier, PKU was, or I may have said, I think I did, that the first condition successfully screened in the newborn period. This timeline shows the process and the time goals for the blood spot screen. So the goal is to collect it between 24 and 48 hours of life, send it to the state lab or KHEL, and then the national goal for reporting time critical abnormal results is 5 days, and the national goal for reporting all results is 7 days. Our team is continuously working to meet and, if possible, exceed these goals. And if you work in a NICU, then you know that there is a little bit, the timeline is slightly different in the NICU. Here is a list of all of the things that the blood spot screen currently tests for or screens for in Kansas. Lots of things. I'm just going to draw your attention to a few that are more commonly known. So primary congenital hypothyroidism, congenital adrenal hyperplasia, sickle cell disease and sickle cell trait, and then CF or cystic fibrosis, severe combined immunodeficiency, SMA is one that we added on pretty recently, as well as the lysosomal storage disorders have been added on recently. So if you think it's pretty big, good bang, well, I would say bang for your buck, but people outside of their taxes aren't paying for it. So it's very important though, and really we strive to get every baby screened. So I wanted to share a few updates on what's going on in the newborn screening world. So as we are winding down on how much COVID testing is going on, things are continuing to normalize for the newborn screening program. We really weren't too affected by COVID, other than some of the staff. My understanding is some of the lab staff were diverted to the COVID teams at different points in the pandemic. I wasn't as involved early on, so I don't know 100% sure about those details, but I remember that being mentioned. There was an increase in unsatisfactory samples. I talked about how my son had an unsatisfactory sample, and that means that the blood samples, which I showed you on a previous card, those different dots, they, for different reasons, were unsatisfactory. And we think that was related to several things, such as like increased turnover of the people collecting it at the birth centers, increasing demands at the birth centers, things like that. And then we did experience a slightly slower timeline early on as we were, again, making adjustments. And again, that was multifactorial, but nothing too significant, luckily. We have a new phone tree at the newborn screening program. So if you need to call us, you can call that number, and then it helps you get to the right person. It's much easier than how it used to work. On March 1st, we started lab online. So that means that PCPs and staff at PCP clinics can access newborn screens for the first 45 days of essentially the baby's life. I think it's technically from when they received the specimen, but about the first 45 days of life. So I put the link there. Feel free to sign up if you would like. I think it's been really helpful, both from the PCP perspective. I know the nurses in my clinic who are the ones doing most of the work to follow up lab results and getting them for us, for example, if they were born at another facility, really like being able to do this. And I think it's also been helpful for our follow-up staff, because they don't have to stop what they're doing and answer as many calls and then fax out the reports, because they're available online. So please take advantage of that. On May 1st, so Monday, we are going to start piloting X-linked adrenoleukodystrophy. So that is one of the conditions that's on the RUSP that we aren't currently screening for in Kansas. So we are excited to add that. There are 2 other conditions. They're also on our radar, and we are hoping to get them going soon. One of them was added to the RUSP last August, and the other one was added just in January. So it's really continuously different conditions are being evaluated, and the group at HRSA is deciding what should go onto the recommended universal screening panel.
Dr. Ben,
Yes.
there's a question in the chat. Can you
Yes.
see that, or would you like me to read it?
I'd love it if you read it, please.
Okay, it says, can Lab Online push electronic version of newborn screen report back to facility and the receiving provider using Cahan Lacey or direct trust address? Can we work with you on this?
Yes, please send me an email about that, and I can find out for sure. I don't believe that's how it sends it. When I've used it, I log in and then search the baby, which can be a little bit trickier than is ideal because it's registered from the date they received the specimen, not the date of birth, but searching by like what the baby's name was. So typically that involves some version of mom's name is the most likely way to get to success. And then it just pops right up like it does when it's in my EMR at least. So send me an email. My email's at the end of the presentation, and we can see what we can do with that.
There's one other comment, if I read it.
No, please do.
This test causes great problems and hard to collect and get correct. Why has it not been updated for years? Can it not be easier? Blood spot.
Yeah, I understand that there can be challenges in doing it. I'm not sure why it hasn't been updated. I think what it does is the spots on the blood spot it's the amount of blood that's needed to run the tests. And they need, I toured the lab when I first started as a medical director, and I'm trying to remember, I don't remember exactly, but they have to be able to essentially take punches in so many spots with the adequate amount of blood in order to run the tests. And so that's why the lab is very particular about if they're able to keep the sample or need a repeat sample. They do have a lot of training materials online, and I'll get to in just a second. We're gonna have a new website soon, so it should be more user friendly. But there are some trainings that can help staff have better success in obtaining the specimen. And then also the newborn, his title, I don't think it's newborn screening educator, but the educator who works with the newborn screening program does go out and visit facilities from time to time. So that's another option. And I was gonna say, we love feedback. So we are trying to get lots of feedback, and please send me all of your feedback, or you can share it here as well. So like I said, we are going to launch a new website hopefully this summer. We are really excited about that. It's going to be much more user friendly than the current KDHE website is, and we are using the KPQC and KMMRCs as sort of our model. So we are really excited about that. One of my goals is that the website be a comprehensive resource on abnormal results for PCPs and their staff, so that it's like a one-stop shop on what to do with those abnormal results. PCPs also and their clinics also get notification letters that have that information, but at least the way my clinic's set up, I get it in my EMR, the result, but I don't get the notification letter at the same time. And so I think it's also helpful to be able to go to the website. So stay tuned for that. I'm very excited. And then the last thing we're working on is that we are revamping the notification letters of abnormal results to parents and PCPs. So we did some parent focus groups, and we are currently doing some PCP key contact interviews to revamp those letters. And if you are interested in participating, we would love to have you. Just let me know. The interviews take about 15 minutes, and a couple of our staff from the fall program are doing those. Here are the data from 2020 as far as the newborn blood spot screen. I should have clarified that in the title. I apologize. So we had 35,643 infants screened. 760 of them had out of range blood spot screens, and they were referred for diagnostic testing, and 56 infants were diagnosed with conditions. The most commonly diagnosed conditions are congenital hypothyroidism, which, just as a side note, studies estimate that 17 to 40% of those are considered transient, and we don't know, we don't have that number for how many are transient, how many aren't at this point in time. Cystic fibrosis, and then sickle cell disease. And one other thing that we are working on from a program perspective, as far as really working to improve what we're doing, is that we are trying to enhance our approach to sickle cell disease and trait, including coalition building, education, and process improvement, which ties into our program's strong efforts to identify and minimize health inequities. So working on that as well. Any other questions about newborn screening? All right, we're going to switch directions. We're going to go to communicable diseases. So congenital syphilis. As you probably know, it is on the rise in our state and our country, unfortunately. About 40% of babies who are born to women with untreated syphilis can be stillborn or die from the infection as a newborn. It can also cause miscarriage, prematurity, and low birth weight. It can cause babies to have the things I have listed there, so severe anemia, jaundice, blindness, deafness, rashes, and even babies who are asymptomatic at birth can develop symptoms later, and those symptoms may become life-threatening and cause their death. And so we all need to work together to screen for this and to get moms treated, hopefully get women treated while they're not pregnant. Second choice, get moms treated while they're pregnant. And then third choice is to know, so that we can at least test the babies and treat the babies as needed. Usually, let's see here, other notes that I had about this. So the treatment algorithm for adults who have syphilis is a little bit complicated, because it depends on the stage of syphilis that the birthing person has, but it is anywhere from a single dose of penicillin G to 3 doses of penicillin G at 1 week intervals, to doing 10 to 14 days of treatment if the patient has neurosyphilis. I am not an adult doctor, and luckily have never had to treat non-congenital syphilis, so I don't really have the details of that down, but that's what sources have said or say when I checked. Let's see here. So here we have the case counts of congenital syphilis in countrywide, so in the United States between 2010 and 2020, and you can see the astronomical increase. I think when I divided it out, it was a 700 or 800% increase from 2012, and this figure doesn't have quite all of the cases from 2020. It has the ones that had been reported by July, but there were 3 more months after that to report them. So it's not fully updated. In 2021, there were even more cases, 2,855 cases. So they keep climbing, and it's also becoming more widespread. So it used to be, syphilis used to be more concentrated in the South and urban areas. And by 2019, 50% of counties across the country reported at least one syphilis case in a woman of reproductive age. Here we have information about Kansas in particular, and this is from KDHE. So I apologize, that text is pretty small, but what you can see is that also in Kansas, rates are climbing. So this is not congenital syphilis. This is not syphilis exclusive to women of reproductive age, but it is syphilis rates overall. And I think we can extrapolate that with syphilis rates going up, it's also going to be going up in women of reproductive age. The other thing to note here is, much like every other thing that I've talked about today, there are significant racial and ethnic disparities. Here we have early syphilis reported to KDHE by county. And so this is in 2020, and 34 of 105 counties were affected by syphilis in 2020. Congenital syphilis, here is the best graph that I found. It's only through 2018, but you can see see how things change. And this is the rate per 100,000 live births. So in our state, it is required to test in the first trimester, and the CDC recommends testing those at high risk and or those who are in high morbidity areas, that they are also tested in the third trimester and when they are admitted to deliver. For example, I delivered in Wyandotte County, my last baby, and was screened 3 times, as is everybody who delivers there. So really, thanks to all of you on the maternal side for working on getting the screening done more completely, so that we can know on the pediatric side when we need to intervene for the baby. And the one thing I'll say about babies with congenital syphilis, the Red Book, which I have right here, but the pediatric Red Book from the AAP, or the American Academy of Pediatrics, is our sort of go-to gold standard for how to treat things. And they've got a somewhat complicated algorithm. When we're concerned about congenital syphilis, I tend to get our infectious disease doctors involved, just to make sure I'm interpreting everything correctly. And I just really have seen anecdotally how hard it is, especially when women need those 3 shots separated by a week, that it can be really hard to get all 3 of those done, and really putting our babies at risk. And so I think, just circling back to what Tara was talking about initially, the social determinants of health, and all of our work in that area, affects so much of what we do, and we continue trying to improve in that area. So as we are transitioning to something more positive, we're going to talk about HIV. Here is my 3rd baby, Anna. She was born in 2021. She's the one who was in my tummy in that picture that was on my intro. And she too was born in Kansas and had a normal newborn screen, thank goodness. So great news about HIV. Just last week, there was an article published in the journal Pediatrics about perinatal HIV transmission. So in 2012, the CDC published a framework for eliminating perinatal transmission of HIV in the US. And the goals were to have an incidence of fewer than 1 case of perinatal HIV per 100,000 live births, and a perinatal transmission rate of less than 1%. So the perinatal transmission rate is the percentage of babies born to HIV positive mothers who acquire perinatal HIV infection. Both of these goals were achieved for the first time in 2019. And so from 2010 to 2019, the number of US-born infants with perinatally acquired HIV decreased from 74 to 32, and that's a nationwide number. The annual perinatal HIV diagnosis rates declined from 1.9 to 0.9 per 100,000 live births, and perinatal HIV transmission rates declined from 1.6 to 0.9%. You can see, again, these are some of the text is pretty small on here, but you can see the reduction in the rates in these graphs. If you look at the 2 graphs on the right, they show that we still have a lot of work to do to get rid of the differences in different races and ethnicities, but at least it is declining. It's declining in every group, but is far from equal. The other exciting thing that just came out within the last few weeks is that the CDC no longer advises against breastfeeding by HIV positive birthing persons if they have achieved and maintained viral suppression through antiretroviral therapy. So that is fantastic. Previously, even though in certain parts of the world, it was encouraged to breastfeed if you had HIV. It was not in the United States, and so the CDC, they recommend shared decision making if the birthing person meets these thresholds, and to provide counseling so that the birthing person can make an informed decision about whether or not to breastfeed. The full recommendations are available at that website, and we are putting it, or I think we just put it into effect at our health system last week. So we are all just thrilled about it. I imagine that many of you can think about patients you've had that this would affect. I had a woman who contracted HIV during her pregnancy or just prior to her pregnancy, and she was devastated about not being able to breastfeed her daughter. And so I'm just so excited that that's no longer the case. And from a global health perspective, HIV positive birthing persons who come from a low resource setting in their home setting or home country, the WHO would have encouraged them to breastfeed because of things like lack of access to safe water and lack of consistent access to formula. Imagine they come to the United States where things are supposed to be better and easier for them, and they're told that they can't breastfeed their child, even though it's the cultural norm for them. And so this is really just such a wonderful thing. It came up at our meeting last week, one of my meetings, and I was so excited it came in time for me to share today. All right, a couple other exciting things that happened in 2022 in the pediatric world focused on newborns and infants. So there was in August on the right side, a new clinical practice guideline revision to the management of hyperbilirubinemia. It replaced the guidelines from I think 2004. So those had been in play as long as I have been anywhere close to being in medicine, and really exciting to get a new set of guidelines that's much more informed and updated with our expansion of evidence in the area. In general, it has slightly, or depends on the age of the baby, but has increased the threshold for babies to get phototherapy, and so helps us from having to light up so many babies, keeps more babies out of the hospital after discharge. There's a great website if any of you are providing clinical care to these babies. If you Google PD tool Hyperbilly 2022, it has a nice program where you can plug in how many hours old the baby is, how many weeks gestation they were born at, and what their bilirubin is, as well as if they have any neurotoxicity risk factors. And then it gives you a nice couple graphs that show you how close the baby is to phototherapy, and then makes recommendations for when to repeat a bilirubin, when they need to be seen outpatient, things like that. The prior recommendations didn't go into as much detail for follow-up testing, and so it's really exciting for those of us taking care of newborns. And then the other recommendations that came out were for reducing infant deaths in the sleep environment. So this was another exciting update for us to receive. And just a reminder for everybody that babies should sleep on a firm, flat, non-inclined surface, that we recommend that they be in the same room as the parents for at least the first 6 months, but not in the same sleep space as them. And that of course, women breastfeeding helps reduce the risk of sleep-related infant deaths, and as well as sleeping in certain things like car seats, strollers, swings, things like that. We want parents and infants to avoid exposure to nicotine, alcohol, marijuana, opioids, and illicit drugs. Make sure that they have the routine immunizations. Pacifier use is associated with reducing the risk, so balancing that with getting latch established when we think about breastfeeding. The guidelines, recommendations, I want to make sure I use the right word. The recommendations talk about avoiding any commercial devices that claim to reduce the risk of SIDS. So a lot of these are those like home heart CR monitors. They don't help. What they do is they stress out parents, and sometimes they give them a false sense of security. So that's not recommended. It is recommended to keep doing supervised awake tummy time to help babies strengthen their neck muscles, so that if they would end up supine, they are more likely to be able to protect their airway. And then they also talked about how swaddling is not a strategy to reduce the risk of SIDS. but it can be used in a safe way until babies start rolling. So those were some pretty exciting changes over the last 12 months or so. And then the last thing I wanted to talk about as far as hot topics was I was going to give just a short update on neonatal abstinence syndrome. So the KPQC's NAS initiative ran from 2018 to 2020. That is when I became involved with the KPQC. And just, not that much has changed, but quick updates. So the nomenclature has evolved. Now we tend to call it neonatal opioid withdrawal syndrome, or NOWS. Right as we were finishing up the initiative, there were statewide trainings about eat, sleep, and console. And so that model of determining what sort of interventions babies need is becoming more widespread than the modified Finnegan scoring system. And then, just like before, non-pharmacologic interventions continue to be the gold standard initial care for babies at risk for NOWS. So I do a lot of counseling on non-pharmacologic interventions when I'm in the nursery. And my this picture on the right, this is my first baby. This is Rita. She was born in 2017, and I saved her for last because she had iatrogenic NAS, as it was called then, and she certainly had morphine on board, but here we are doing our best to also maximize non-pharmacologic interventions with skin-to-skin time, a pacifier, and we tried to keep the room dim and quiet as much as possible in the NICU. And I always have to thank former KPQC chair, Dr. Jody Jackson, as well as Betsy Knappen, who previously had Tara's role, who were clinically cared for my daughter, and I really think Dr. Jackson as playing an important role in saving her life. And so I'm always and forever grateful to both of them. And that's really how I became involved with KPQC. After Rita went through NAS, I worked hard to make sure that she wasn't born at my health system. She was born at Advent Shawnee Mission, but I worked hard to make sure we were doing the best we could at KU to help take care of babies at risk for NAS. And then that led me to Dr. Jackson and Betsy, and led me to KPQC. So that was the silver lining of what went on for my sweet little Rita. And she's 6 now, and she's great. All right. So the last thing I wanted to do, just check. Oh, okay. Right on time. Last thing I wanted to do is to just go through some gaps in newborn care. And again, I give a big thank you to Brenda Bandy. This image on the right is hers from the Kansas Breastfeeding Coalition. It highlights areas where hospitals can increase their breastfeeding support. So number 4 on my list is to provide optimal breastfeeding support. So I was just realizing that I should have probably put a verb under racial inequities. My apologies. I think I put that at the top of the list and then didn't go back and look at that. But so we want to be continuing to work to decrease racial inequities, just like is going on in all of our work with the postpartum, the 4th trimester initiative, as well as our work just in our day jobs, to be mindful of those inequities and doing what we can to help overcome them. Safe sleep wise, so it's important, very important, that birth centers are modeling safe sleep. Studies that have been done show that they consistently do not model safe sleep. And if you think about it, that makes it hard for parents to understand, okay, my baby looks like this here, the team put them like this, yet I'm being told something different, and the expectation is not that I have them match what I saw in the hospital. So we want to work hard to be implementing all those safe sleep practices in the hospital, particularly in the newborn nursery. Obviously, babies in the NICU, they're on monitors, and the situation is different, but really wanting to model that. And then also counseling. So I am wrapping up, I guess I should say, a study on parental perceptions of safe sleep and the care they received at my health system, and they received a free crib because they didn't have a safe place for the baby to sleep. And whether or not they were fully implementing the sleep recommendations, they were all adamant in interviews that we continue talking to them, to continue providing counseling, for continuing to educate families, because the more they hear it, of course, in a supportive way, in a non-stigmatizing way, the more they hear it, the more likely they are to implement those. And so just knowing that each and every one of us, as we counsel on safe sleep, we are potentially saving babies' lives. Then also tobacco cessation counseling and support. Tobacco exposure increases babies' risks of SIDS and SUID. Optimal breastfeeding support for so many reasons, to decrease sleep-related, SIDS deaths, but also to improve outcomes in so many other ways for babies and for moms. Making sure that all babies are getting vitamin K, erythromycin, and hepatitis B. I didn't touch on that, but vitamin K prevents bleeding, so important things like intracerebral hemorrhages, erythromycin to help prevent conjunctivitis, and then hepatitis B vaccine to prevent congenital hepatitis B infections. Getting newborn screening for every baby on our list. I saw that not every baby is getting screened, unfortunately, so working hard to do that. We want to keep up with car seat safety counseling and checks. I know when my kiddos were born, we had to have a non-expired car seat for the team to look through and approve. Because traffic accidents still cause babies' deaths, even though that doesn't make the list of the most common things, thank goodness. And then I can't ever give up the opportunity to advocate for paid parental leave. I'm sure you all agree with me that's important. I think one of the things I have found through my work over the last 10 years or so in this area is that so much of what we want to see implemented but doesn't get implemented is because of a lack of paid parental leave and the lack of support for families with babies and young infants. Finally, please keep up your 4th trimester initiative efforts. In so many ways, what you're doing with the mom is helping the dyad and helping the babies, and a reminder that that SUID is the #2 cause of death, which I think that moms who are not optimally, in an optimal position are, I don't have data. I'm sure that, well, I would think there are data, but I don't have any off the top of my head. So I can't say, I promise it, but I think probably may practice more unsafe sleep practices. That short gestation and low birth weight, #3 cause of infant mortality, is directly related to so many things in the postpartum, as well as the prenatal time, and then maternal complications of pregnancy. And so trying to get those under control before women get pregnant. So please keep doing it. And with that, that is all that I have. Like I said, we have 3 more minutes. Please email me with any questions or feedback. Here's my email, and it can be about newborn screening or anything else. A huge thank you to KDHE's newborn screening staff, to Brenda Bandy with the Kansas Breastfeeding Coalition, my colleagues in the KU Newborn Nursery, including Dr. Pressler, our medical director. They helped me put this together. And a huge thank you to Tara for inviting me. I'm excited again to talk about this and happy to entertain the questions we can in the next couple minutes.
Well, Dr. Bettinger, thank you so much for speaking for us today. I think there was one more question in the chat. Tiffany, do you see that?
Yes. One question was about the website for the billing numbers that you talked about. And I'm happy to send that out in the follow-up if you don't have time to put it in there. And then there was a request for THC conversation in the future, use of THC, and then the website for training on newborn screening.
Okay, I will get both of those websites to you, Tiffany, and then yes, THC use is a whole other area that I did not touch on today, and I think we can stay tuned, and I'd be happy to talk about that on another occasion.
Love it. Do we have this last slide, Tiffany?
Yes, just putting it up right now. Can you see that?
Yes, perfect. Okay, thank you all so much for joining us today. We just wanted to do one last reminder about our spring conference. Make sure you get registered. If you're an FTI champion or part of the executive committee, be sure to register for in-person. Everyone else, we'd love to see you virtually for this. We're pretty excited about this conference and just looking forward to everyone's attendance. So if there's no other questions, we will adjourn for the day, but thanks so much for everyone for joining.